Jan, I got to mention some big birthdays today. On April 6th, Zach Braff, JD from Scrubs, one of the classic medicine sitcoms. Paul Rudd, who I don't think has aged a day since I was introduced to Paul Rudd. And I think the biggest of all, maybe a little bit kind of underappreciated, Billy D. Williams, Lando Calrissian himself. Jan, I know you and I both, big Star Wars nerds. How do you feel about Lando? Lando, your guy?
So, yeah, I'm a big Lando fan. He's definitely a cool cat. I remember him kind of walking into the scene in Empire Strikes Back, I think was the first time I really met Lando. Yeah. But, as you brought this up, I had Googled him just because I was like, I don't know how many movies he was in. Let me just get a little deeper into it. And what you find yourself doing is going down these rabbit holes of these like fandom wiki pages with all of this background about these characters, like where they grew up and who they're, it's just amazing how much information the Star Wars nerddom out there
goes deep. It goes very, very deep. Yeah, I'm a huge Lando fan. I feel like when Lando came in Empire Strikes Back, you were like, oh, look, in a galaxy far, far away, they got style too. I think he was like the first one who brought some style into. And listen, Harrison Ford looks great. We've already kind of professed our love for Carrie Fisher in the past, but Lando's style, it was just something completely different. And I got to say, Jay, I know when we've talked about Star Wars, you've said, I don't love the newer movies as much. Like, I really like the old classics. I'm there with you. But one of the things that I love is when they did Solo, which is about Han Solo, they reintroduced like the Lando character and his backstory, and it was Donald Glover. And I'm a huge Donald Glover fan. And what I want is a Lando Calrissian standalone TV show with Donald Glover. Maybe it's too late now, but that's what I'm asking for. And I just think Disney should get on it. So everyone out there that's from Disney who's listening to this podcast, which is like a single digit number, I'm sure, let's get this to happen. Let's get a Lando series with Donald Glover. Jan, is that too much to ask?
No, I think you're onto something here because I think that would be quite popular. This is a character from the fandom pages I've read.
Yep.
He has got quite a following and people who are interested in his trajectory. And so I'm down for it.
All right. Well, we're going to make it happen somehow. Maybe we'll rally all of the vast funds and wealth that Mel is sitting on, and we'll make this Lando show. But before we make the Lando show, let's get into our case of the month.
All right, let's do it. So, Swami, you're working a shift. The booth in front of you, you got EMS rolling in. They're bringing you a 93-year-old patient from a nursing home. The guy is kind of the frail, elderly patient lying on his side. That's what you see. And the EMS tells you that this patient's being brought from the nursing home because of coffee ground emesis and that he had a low blood pressure. And en route, his blood pressure has been like 80/40. And they say this is just the way he's been all the way here. And they seem to be slow rolling it. They're not rushing in. They're going to offload him onto the gurney. So I want to kind of get your initial thoughts about what you think of this elderly patient, low blood pressure coming into your booth.
There's two different pieces here, right, Jan? There's the medicine part of this, which is there's a guy with coffee ground emesis. It's an upper GI bleed, most likely, and I should be really worried about that. And I'm going to rally a bunch of resources to take care of that patient. And then you have to add the 93-year-old frail part of this, because we know that GI bleeds have a significant mortality. Now you add to that advanced age, frailty at baseline, and we've talked about this before, Jan, not every 90-year-old is the same, but this guy sounds like he's kind of baseline pretty sick. So I'm thinking about balancing the aggressive resuscitation with also, are we getting to the point of having to talk about palliative care and stuff? And I know that's not where we all rush right at the initial seeing the patient, but you have to in these kind of circumstances.
I think, of course, that's absolutely right. You have to kind of step back, look at big picture. Here's a 93-year-old. He's got a low blood pressure. 93-year-olds who are in the process of dying have low blood pressures. Am I just seeing this person in this part of his trajectory? Or was this a pretty, a relatively stable 93-year-old that now has some decompensation that I need to deal with? Where am I, because we all have seen relatively vibrant 90-year-olds. This doesn't look like that patient. He's coming from from
Right.
a nursing home. It's probably not that one, but you want to give people the benefit of the doubt. Now, we work in an emergency department. So in this moment, the nurses are rushing over. They're getting him hooked up to the monitor. They're telling you, doc, his pressure is 75/30. He's got some dried coffee ground around his mouth. They want to know what you want to do next. So Swami, what do you want to do next?
So the residents and a lot of the younger nursing staff is going to be rushing in to do all the aggressive things we always do on these upper GI bleeds, which is exactly the response that they should have. And then our job as the attending is to kind of just take a little step back, say, where's the paperwork that the patient came with? And let's find out what meds the patient is on and what medical problems they have, but also what was their baseline status before this happened? What, if any, do they have advanced directives? And I need to know about those. So while everybody is going to the bedside to start that resuscitation, I'm probably going to grab those papers and start flipping through those as they're starting that resuscitation.
Yes, that's exactly what I did. I went right over. Luckily, there's about 5 pieces of paper they brought with them from the nursing home. And there is a POLST there. So for those of you who are not familiar with what POLST is, it's a physician's order for life-sustaining treatment. Sometimes it can be called other things in other states here in the U.S., but he does have a POLST. It's signed. It was from 2022, and he has the box checked that says he would like selective treatment. So usually on a POLST, for people's background, there's 3 categories that you can choose from. It's a menu of options. There's basically a full treatment category, there's a selective treatment category, and there's a comfort-focused measures only category. And basically, as you can imagine, that middle category is, I don't want all the really invasive things, but I'm open to IV antibiotics, I'm open to oxygen, I'm open to basically looking for reversible causes. I kind of interpret that as.
This is actually tricky because if it is the all court press kind of situation, you know what to do. And if it is the comfort measures, you know what to do. It's that middle one that can be really challenging. The nice thing about it is that often this does leave a little bit to interpretation for us as physicians to say, is this a reversible issue? Can I fix this problem? Can I get the patient back to whatever their baseline was? And Jan, a lot of that decision is going to be very individualized. And I'm not standing in front of this patient, but from what you're telling me, I don't think that I can reverse this situation. This might be the patient's dying hours or minutes, or maybe it's a day or two. But this to me sounds like an irreversible situation, especially when I think about the fact that I can't actually fix the problem. Right? If they have a bleeding peptic ulcer or bleeding varices, I need to get somebody else to do that. And we kind of know that a lot of our consultants that are proceduralists are a little bit reluctant to be really aggressive in doing those procedures on patients who already have POLST forms, that already made decisions. So I might look at this patient and say, I don't think this is a reversible cause. Let's make sure that the patient is comfortable. Whereas another physician might look at it and be like, no, we're going to give them blood. Blood's not a painful procedure, so we can give them blood and we'll call our consultants. And, if the consultant doesn't want to scope them, that's up to them. But I don't know, Jan, I think that I might be a little bit more prescriptive with what I'm going to do here. So I don't know, what were you doing? Were you rushing to get blood on board for this patient, reverse anticoagulation, those kind of things?
Right. No, I wasn't. I was more interested in getting a hold of family, and then also seeing if the patient can talk to you. So in some of these circumstances, you can talk to patients and sort of run through this with them. Often you're left in these situations where you can't. So as I go to the bedside to this patient to kind of see where we are, he's curled up in a ball. I grab his hand and he squeezes my hand, so I know he's there. I ask him to open his eyes. He kind of half opens his eyes, so he's trying, but he can't really fully open them. He's not talking to me. So I don't really know what his mental status is at this point. I ask him if he's in pain, squeeze my hand. So, interact with your patient, see if you can at all interact with them on any decision-making capacity, and also to assess sort of what their baseline is. And then I think the next step is to get on the horn with a family member or decision maker to see if you can talk with them through where you are at this moment and what the options are. Now, I think we don't need people to tell us what to do medically, like you said. I mean, I kind of know where I want to go with this case, but I want to make sure the family is sort of right there with me, because they are ultimately the ones that are going to be dealing with this as their grief process starts, because I think we all know where this case is going to go. So, I'm going to call a family member. So, Swami, as you approach a phone call to a family member at home, you're starting this conversation. Tell me some pearls about how you start these conversations.
I think in this kind of a situation where you're pretty clear about what the trajectory is, you have to be very clear in expressing that to the family. You can't necessarily leave this sliver of hope if you don't think it's there. Now, if you think, this is pretty minor, I don't really see a ton of bleeding, etc., fine, you can communicate that, but you got to be honest with your assessment. Again, I'm not in front of the patient, but 93-year-old, relatively frail with a GI bleed, I think I would tell the family this is probably a terminal event. And it's just a matter of when. When is this going to happen? So, one of the things that family always asks is, should I come right now or can I come tomorrow? This is a situation I'll be like, you should probably come now. You should probably come now and be with your family member while there's still time. I think those are the kind of conversations that you have to have. And it's hard to do that on the phone, but I want to be honest with the person and tell them that. And then, I want to ask them, of course, what would they want? Because while giving blood might not be painful, there's a lot of things we're going to do that can be painful. And we want to just express, even putting an IV in someone who's a little contracted and frail can be very uncomfortable. So I want to get a sense from them of, what do you think your father or your loved one would want in this kind of a situation?
Yeah, I think that's spot on. This particular family member, he had seen his father maybe a month ago. He lives about 3 hours away. He says that his father at baseline does have dementia and has been in this nursing home for a while. He's had a bunch of chronic medical problems. But the last time he saw him, he sits up, he has his eyes open, he's able to converse. So this definitely represents a decline for him, an acute decline. And he doesn't know really, he wasn't even aware that his father had a POLST. He didn't know what that was or the fact that that existed. So we explained that your father has told us what his wishes are, and this is what the document says. Do you know if he would be opposed to a blood transfusion or not? Just to see if, yes, he's a Jehovah's Witness or, get something out of him. He basically said, I don't know whether he'd want that or not, but I would like to see my father. So, like if you can keep him alive, that kind of a thing. He understood where we were going, but he wanted to make it to the hospital. And he was about 3 hours away, as I mentioned. So my goal after that became to try to keep this man alive for 3 hours at least until his family can get there. Because we also know that grief is a complicated thing, and people being able to come to the hospital and say goodbye to family members is not only important for patients, but very important for the grief process for family members who are, the primary caregivers and associated figures. So I wanted to try to temporize things to allow time to get this family member there.
And that's no small ask, Jan. Keeping this guy alive for 3 or 4 hours is not a small feat. That might take quite a bit of work and interventions and resources to do that. And so we just have to keep that in the back of our mind. It's not that I'm not going to do it, but this conversation could have gone very differently. The son might have said, it's not just that he wouldn't want blood or wouldn't want to be intubated or wouldn't want to put on an event. He really wouldn't want to take resources away from others. That's a very different conversation. And it really tells you, okay, I'm just going to then aggressively take care of this patient and make them comfortable. And that's where my focus is going to be. You're not getting that in this kind of a situation. You're really getting, can you keep him alive so I can see him before he dies? And that's really a lot to ask for. But I think what that says is if I'm going to try to do that, then I'm going to be treating this person like they're a 30-year-old with an upper GI bleed. And that's a lot to ask for.
I think it is. And this is one you struggle with, right? Like, there's no right answer to this case. So anyone who's listening to this story and thinking I would do something differently, you're not wrong. I think that this is really a in the moment decision. So for me, I thought, I'm not going to do anything invasive here, but I think supporting him to the next 3 hours is reasonable until the father comes or till the son comes and he can see his father, and then things are going to go pretty quickly. So for me, I thought, let's do what we can to support him. That means let's give him some IV fluid. If we need to give him a low dose of vasopressor peripherally, we're not going to do any central lines. We're not doing anything invasive, but that would be okay. If we want to give him 1 unit of blood, I think that's okay. We're not going to be emergent about it. We're not rushing to the blood fridge that we have in our resus trauma area and rushing in a unit of blood, but we could get him some blood if we need to do that. But in the meantime, let's just try to support him in this non-invasive way until his son can get there and say goodbye.
I think that's all really reasonable. And the one thing that I will kind of remind people is we have many times in the past said that peripheral vasopressors are totally fine. But remember that you want to have a really good line that you're giving those peripheral pressors through, because if there's extravasation, that's going to be painful. We know that. We know that because when things extravasate, our patients let us know that there's extravasation going on. Extravasation of peripheral pressors can be very painful for the patient. So if you're going to do that, just make sure you have a solid line that you're doing it through.
Yeah. The final issue in this case that I want to bring up, because I think probably a lot of people cross this bridge as well, which is, okay, so we've started a little bit of low-dose peripheral Levophed or norepinephrine. That's supporting his blood pressure a little bit, just a few mics. He looks very comfortable. He's not in any pain. But then you're going to admit him. I'm going to admit him. I'm not going to keep him in the ER for 3 hours because you don't know. Death trajectories are different from person to person. I don't actually know how long it's going to take. I don't know when the sun's going to get there. I don't know how it's going to go. So I'm going to admit this person. And so the next question is, where do you admit him to? Because if you have someone now on a peripheral pressor, right, they're not going to just go to any old ward bed. Now, if you have a comfort care bed and you have protocols that allow patients like this with those kind of blood pressures to go to those beds, you have nurses that are, equipped to take care of it, that's one thing. But a lot of people work in places where there's no ward or step-down unit that's going to take a patient with a blood pressure of 70/30 who's on peripheral Levophed. They're just not going to do it. It's just like against their standards. And so then you're like, I have to put this person in the ICU. And now you've got back to the resource question, which is, what is the right answer to this question? So in this particular circumstance, we called the ICU, explained the circumstance, and of course, immediately the ICU fellow was like,
Nope.
This person should not come to the ICU. There's absolutely no way. This is not a good use of resources, etc. And I want to know how it works in your hospital.
I think I would get the same conversation. So I know that this person should not go to the ICU because that ICU bed, which is a rare commodity in both of our hospitals, Jan, needs to be saved for somebody where they're going to be aggressively managing that patient, where they need that, 1-to-1 or 2-to-1 nursing. This is not going to be that situation. And so I know they're going to say that, but I'm still going to call the ICU fellow and I'm going to let them say, I don't think this is the appropriate use of the resources. We recommend that the patient go to the floor, because then it makes the conversation much easier on the other side when I admit the patient to the floor and I tell them, hey, I already talked to the ICU doc. The ICU doc said no. We just don't have the resources to put this patient there, and they recommended this patient gets admitted to the floor. It just makes that conversation much easier. So I'm going to have the conversation with the fellow. I'm going to be just as open and honest as I was with the son on the phone. Tell them this is not a reversible scenario. This is probably this patient in their last hours to days of life, and I don't think it's a good place to use the MICU, but we need you to agree with that before we push the patient to the floor.
Yeah, and I think just for everyone, again, like this scenario could go a lot of different ways. If you work in a place where there's no ICU beds, you may hold this patient in the ER for 3 hours until the sun comes, and that's totally fine. That is one option. If you work in a place where you have protocols, and mostly this is a nursing thing. It's
Absolutely.
not a doctor thing and comfort. It's a nursing standard thing that this patient with these vital signs and that medication going cannot go to one of our ward beds. It's going to be different. And if you had no ICU beds, if I had no ICU beds on that day, I would not have put this person in the ICU. But it turned out on this day we had 5 open ICU beds. And we actually had very few in the middle beds, the tele step-down beds, and we had like 40 ward beds. So in this case, I talked to the ICU attending. I explained where we were in this scenario. There's no way we're going to send this person to a ward bed. They're never going to accept them. We have 5 ICU beds. Can we put this person up there with this plan, with the sun coming? And they said, fine. Like, yeah, we're happy to take it. It sounds like they're not going to be here for all that long. Look at the sun here. Let's get the pressors off, and then we'll see where it goes. And it turns out, just to wrap things up, that this patient did go to the ICU and died about 6 hours later. The son was able to get there. They were able to have a conversation. They took the pressors off, and he died pretty quickly. So in the end, this patient got what he wanted. He didn't get put through any additional pain. He didn't get extra pokes. He didn't get a whole lot of anything done to him except for some supportive care. The son was able to come and say goodbye to his father and hold his hand and be there as he died. And in the end, yes, an ICU resource was used, and you could say that that's incorrect, and he should have just stayed in the ER or gone to a ward bed. But this is going to be where it's customizable to where you work
right.
and what you need to do.
And Jan, I just want to just say one more thing before the listeners write in and say how I'm a heartless bastard for saying that this patient's going to die in a couple of hours. Let's not put him in the ICU. Let's not use those resources. I do want to just put a little caveat there, which is that if the patient was in pain, if I did have to give them pain medication in the emergency department to make them comfortable, and I don't have a situation where I have a hospice area or a palliative care bed, I really would consider putting him in the ICU for that aggressive palliative care. I want somebody checking in, seeing this patient is uncomfortable, giving them pain medication to make them comfortable. And sometimes floor beds can't do that. And that's not because the nurses don't care, they don't want to do it. They just have other patients that they have to take care of. And then maybe the ICU is the best place for this patient to die with a little bit of dignity. So I think that really you have to know your institution, you have to know your resources, you have to know the patient in front of you a little bit to know, am I going to be giving this patient rapid succession of pain medications in order for them to stay comfortable, which isn't going to happen on the floor. So then that's a really good reason to use the ICU resource.
Yeah, I think that's right. And so some take homes here, comfort care and end of life care can be aggressive. And sometimes it needs to be done in ICU, as you just very eloquently stated. And if you can think ahead to these scenarios and get protocols worked out and have comfort care beds where people are comfortable with this type of care and they don't need to consume an ICU resource, great. That is like the ultimate solution. But few of us have that kind of customized bed and nursing plan and protocols in place. It's something to think about. But comfort care can be very aggressive care in supportive care, pain management, as you mentioned. A lot of nursing care can be involved in positioning and just being there at the bedside to support a patient through the end of their life. Getting family there is probably one of the more ultimate goals in all of this, if possible, to try to think of that family as part of the patient experience, not just for their dying experience, but for the patient's grief and the family's grief, and trying to make sure that they have a grieving process that will leave them in a place that they can move on with their lives and not be traumatic in an experience. And then finally, POLSTs are really helpful. These advanced directives are super important, but sometimes they don't exactly explicitly state what it is you're considering. So for example, a POLST doesn't say anything about a blood transfusion. It doesn't say anything about vasopressors. And so you have to make interpretations about what this patient wants, what their goals are, and then what your options are and how it fits into that picture, because it's not going to outline everything that you may be faced with choosing between.
Jan, thanks so much for bringing this case. I think it highlights so many important issues for us to discuss. I'm sure there'll be lots of listeners writing in about things they would do differently or challenges they would face in their hospital with managing this kind of a patient. Of course, we love seeing those, so drop those in. And with that, Jan, let's launch into the rest of the week, because we do have some really fantastic stuff coming up. We've got a risk management segment, which, I don't know, Jane, you remember a couple of months ago, Mike did a case of a missed pulmonary embolism. This is kind of the follow-up to that piece with Scott Weingart, whose case it was, talking about kind of how they manage this and why they made certain decisions, and also how they do their documentation. We've got a little short piece from Al Sacchetti on atrial fibrillation. We've got a longer piece with Tarlin on amio and lidocaine and VF or VT. This one is a little bit different than the one we did couple of months ago with Haney Malamet. So really, you want to listen to both of these together. But before we get to any of those, Jan, we've got a couple of papers from last month's EMA. So let's dive in.